Hello everyone and welcome back to my channel. So we are going to start the rheumatic diseases and we will discuss the two important rheumatic diseases, that is juvenile idiopathic arthritis and Henoch-Schönlein Purpura. Okay, so starting from our first topic, we are having a scenario that there is an 8-year-old patient having swelling and pain in all her joints for the past 2 years. Joints are stiff and more painful in the morning. She has been using medicines for the pain, but there is temporary relief. She has difficulty in writing or holding things firmly. She has no fever, diarrhea, or any other complaints. On examination, she has no fever, diarrhea, or any other. She is afebrile, has swollen interphalangeal and metacarpophalangeal joints with some flexions. Now, another scenario is that there is a 7 years old girl presented with history of joint pain and swelling for the last 2 months. She has difficulty in getting ready for school early in the morning. She is fully vaccinated and both upper and lower limbs are swollen and tender. She has no visceromegaly and lymphadenopathy. HB is 10 mg per dl, TLC is 55,000, platelet 1 leak 80,000 and ESR 98 and SO titer is 100. Okay, so what is the diagnosis, the investigation plan for her, and the management and the 3 complications? We are having another scenario that there is a 4-year-old girl with history of joint pains and swelling, fever of last 8 weeks, and she is pale looking, have swollen and tender wrist, ankle, and knee joints. Small joints of the both limbs are also swollen. Lymph nodes also palpable, and heart sounds are normal. Okay, so we got the diagnosis from this scenarios that there are swollen joints and multiple joints, that are wrist, ankle, and knee. So all joints are involved, and there is difficulty for the patient to go to school or whatever, means that this joint swelling or pain is affecting her normal life activities. So we are having the diagnosis of this defect as juvenile rheumatoid idiopathic arthritis. Now we are having the definition that it is a chronic arthritis that persists for a minimum of 6 consecutive weeks in one or more joints, and before the age of 6 years and after active exclusion of the other causes. Okay, what is rheumatoid idiopathic arthritis? It is a chronic arthritis that persists for minimum of 6 consecutive weeks in one or more joints, and it occurs before the age of 6 years and after active exclusion of the other causes. Now, the causes of the idiopathic arthritis are unknown. There is maybe immunogenetic susceptibility and environmental triggers may be present. Viruses like parovirus, B19, rubella, and Epstein-Barr virus also can aid to the rheumatoid arthritis. This can also be the cause. So the classification are having, we are having the types, that is systemic onset of the disease, polyarticular onset, and oligoarticular onset. In the polyarticular onset, we are having rheumatoid factor negative and rheumatoid factor positive. Both are the types of polyarticular onset. The investigations that are done are, there is no diagnostic test for juvenile rheumatoid arthritis. The ESR is high, hemoglobin is low, and normocytic normochromic anemia may be there. WBC is raised, that is neutrophil leukocytosis. Platelets are raised. Oligoarticular joint involvement, that is platelets are normal. IgM rheumatoid factor is negative but may be positive in polyarticular onset disease. Antinuclear antibodies are negative, and radiographically early changes of the affected joints are there. Now, the management options for juvenile rheumatoid arthritis are restore function, relieve the pain, and maintain the joint. Okay, then physiotherapy is done, which is important for the joint mobility. Bed rest is provided in acute stage, and NSAIDs are given to control the pain, inflammation, and fever. And aspirin, naproxen, brufen, diclofenac is given. Methotrexate is given for 3 to 4 weeks and for a symptomatic response. Corticosteroids are given in severe diseases. Cyclosporins are given for systemic features. Splinting is done for deformity. Surgical interventions are done, such as replacement, arthroplasties, and is often required. Then frequent ophthalmological assessment is done, which is needed to prevent and treat the iridiocyclitis. And DMARDs, toximab, hydroxychloroquine are given for the rheumatoid arthritis. The clinical features are autoimmune, which is common in hands and wrists and small joints, and stiffness is greater than for 1 hour, and rapid onset of the stiffness occur. The complications are permanent joint damage to the joint, interference with the child's bones and growth, chronic long-term arthritis and disability, that is loss of the function, vision problems including loss of vision caused by uveitis, inflammation inside the eye, metabolic disorders, psychosocial health, It affects the quality of life, and loss of mobility occur, weight gain occur, and spreading of the inflammation occur. These are the complications of the juvenile rheumatoid arthritis. So we have discussed the case of juvenile rheumatoid arthritis, that there is the history of multiple swelling in the multiple joints, and this defect is affecting the normal life of the patient. This is rheumatoid arthritis, and we have some diagnostic points that there are multiple swollen joints, and she is having it is affecting her daily life routine. We have discussed the definition, that it is a chronic arthritis and which lasts for minimum 6 consecutive weeks. Then we have discussed the different causes, which are the unknown causes, the immunogenetic susceptibility, the environmental triggers, the viruses like parvovirus, B19, rubella, and Epstein-Barr virus. Then we have discussed the classification. We will discuss the different types, which are systemic onset of the disease, polyarticular onset, and oligoarticular onset. Then we will discuss the investigations, which are no diagnostic test for JRA, then ASR, then hemoglobin, WBC, platelets, oligoarticular JIA, IgM, rheumatoid factors, antinuclear antibodies, and radiographically early changes of the affected joint. Then we will discuss the management, which are physiotherapy, restoring the functions, bed rest, NSAIDs, methotrexates are given, corticosteroids are used, cyclosporins for systemic factors are used, splinting for deformity, surgical interventions are done, frequent ophthalmological assessment is needed to prevent iridocyclitis, DMARDs, toximab, and hydrochloroquines are given. The clinical features are autoimmune, and these are the complications. Now coming towards the next defect, that is Henoch-Schönlein Purpura. We are having a scenario that there is a 6-year-old boy who having flu-like illness 2 weeks ago. Now he has pain and swelling of both his ankle joints, pain, abdomen, and reddish spots over his limbs and buttocks. He is afebrile and fully conscious. And the scenario is that there is a 9-year-old girl admitted with the complaints of pain and swelling of both ankle joints and pain abdomen for 1 week. Today, she developed many reddish raised spots over her upper and lower abdomen involving her buttocks as well. She had severe colicky abdominal pain and passed blood in stools and urine. So here we are having the history of joint pains. Then another thing is that there are rashes over the abdomen. Then there is pain abdomen. And also there is blood in stools. So these are the major diagnostic points for this disease, that is flu-like illness, pain and swelling of ankle joints, pain abdomen, and reddish spots over limbs and buttocks. Okay, so we are having the definition that a systemic IgA-mediated vasculitis involving the skin, joints, gastrointestinal tract, and kidneys. All of these things are involved in this disease. That is the first one is skin, then it also involves the joints, then GI tract is also affected, and then the kidneys are affected. This is autoimmune disorder, that is Henoch-Schönlein Purpura, and the clinical features are rashes, arthralgia or arthritis, gastrointestinal, renal, neurological, and like symptoms. The investigation options are ESR is done, which is normally high, complete blood count, which is usually normal, hematuria or proteinuria may be present, blood coagulation studies are normal, and IgA complexes in glomeruli and involved also the skin. Serum IgA is often raised. Stool examination is done, which may be positive for blood, but melena is not present. Anti-streptolysin is so frequently raised, and throat culture is positive for group A, B, hemolytic streptococci. This is the main thing, that the throat culture is positive for group A, B, hemolytic streptococci. Now the differential diagnoses are thrombocytopenic purpura, meningococcemia, child abuse, Crohn's disease, and Weger's granulomatosis, infective endocarditis, IgA nephropathy, hemolytic uremic syndrome. These are the differential diagnoses of the Henoch-Schönlein Purpura. The complications are interception of the small intestine and renal failure 5%. The management options are the general treatment is provided, that is supportive, corticosteroids are given, which is used in severe diseases, may provide symptomatic relief for severe gastrointestinal or joint manifestations, but does not help for skin manifestation. Aspirin is used for pain of the arthritis, and ASO titer is positive. Penicillin is given for 10 days. So we have discussed the important topic, that is Henoch-Schönlein Purpura, which is an autoimmune disease, and which there is the involvement of the skin, the joints, the GI tract, and the kidneys. So the rashes on the skin appear, the joint pains in multiple joints appear, and there is vomiting or GI illnesses, and there are also urinary or kidney symptoms. So we have discussed the definition of the this disease. Then we have discussed the clinical features, which are rashes, arthralgia, gastrointestinal, renal, neurological. Then we have discussed the investigations options, which are ESR, complete blood count, hematuria, and blood coagulation, IgA complexes, serum IgA, stool examination, anti-streptolysin ASO frequently. Then the differential diagnosis are thrombocytopenic purpura, meningococcemia, child abuse, and Crohn's disease. These are the complications, and then we have discussed the management options. In the next part, we will start the respiratory unit of the pediatrics, and we will discuss the asthma and the rest of the diseases. Thanks for watching.